Okay, hi everyone. So welcome to today's episode of the Referrology series on the sick patient. So today we have Dr. Jared D'Souza as well as Dr. Tan Roan, who isn't here yet but will hopefully join us shortly. Both Dr. Jared and Dr. Roan are both dual accredited in advanced internal medicine as well as critical care medicine. So today we are very fortunate to have them to answer the questions that we have with regard to attending to a sick patient. So with me, I have Dr. Rachel Cho, who will be asking the questions together with me. So maybe we'll start off with a case scenario, and then we'll just loosely tie the discussion around this case scenario. So Madam Tan's a 65-year-old female with background hypertension, hyperlipidemia, and DM, and hypertension. She was admitted for 4 days of fever, vomiting, left flank pain, with a positive renal punch, and was found to have raised total whites and a pyruvate eupheme. So she was treated as for likely left pyelonephritis with IV augmentin. And a couple of hours into her ward admission, the staff nurse noticed that her blood pressure was low at 83/54, and hence the ward MO was called. So I've broken today's discussion into circulation, breathing, and airway. Perhaps we'll entertain some of the questions pertaining to circulation first. So I guess, of course, looking at the appropriate, after ensuring that we've given appropriate antibiotics, there is the big portion on fluid resuscitation. So I think one of the challenges that juniors have on the ground is exactly determining how much fluid to give, especially at the outset. So Dr. Jared, how do we normally determine this?
So in my experience, there's like two ways to go about this. I think to answer the question very politically correctly would be, if you ask me how much fluids to give, I would say as much as the patient needs. And I guess you come to the point with how to determine as much as the patient needs. So there are a few factors that you need to take into consideration. I'm not sure if you read this book by Daniel Kahneman called Thinking Fast, Thinking Slow.
Yep.
Okay, so in that book, they talk about these two aspects of decision-making, the fast side and the slow side. When you're in this state where you see a hypotensive patient, my first response, and I would encourage everyone's first response to be to get a bag of fluid and to run it. It buys you a little bit more time to actually think about what exactly is going on. So the etiology. If it's acute blood loss, you can give all the fluid you like, but that may not be appropriate. That's what I'm trying to say.
Yep.
So some of the ways you can calculate, if you look at the surviving sepsis guideline, they do advocate giving 20 to 30 mils per kg in the first hour of resuscitation, right? Some of the things that I do is a quick assessment at the bedside. Now, it can be in the form of a quick examination, a quick set of vitals, as well as a POCUS assessment. So if you're looking at a quick examination, simple things like mucous membrane. In kids, we used to look at under their eyes to see whether it's sunken or not sunken. But actually in the elderly, it works very well. So you can actually see most of them tend to have sunken eyes, but you can look at mucous membranes, you can look at skin turgor, right? Other quick sort of assessments, I also look at the urine in the bag. If there's an IDC, if the urine is really concentrated, these kind of like all build towards the picture.
Yep.
You can also look at other things as well. What's the primary reason? Has the patient been having vomiting, diarrhea? Anything that causes this fluid losses cues you in on the fact that the patient needs more fluids than as compared to other patients.
Yep.
Now, if you want to do a quick blood pressure and heart rate, I think hypotension and tachycardia are very universally accepted, right? And we tend to use them as surrogate markers for hypovolemia. But there are other things you can look at as well. So pulse pressure is a measurement that can be also gauged. And this is buried in the blood pressure reading. So you don't need to do any extra equipment.
Okay.
Basic tests like a lactate tells you how shocked the patient is, probably. It doesn't tell you how much fluid to give though. So you have to keep that in mind.
Yeah.
A volume assessment does guide you that the patient is hypotensive. And you can do that at the bedside with the echo. But of course, that requires operator training. So at the resident level, I would say, probably that's something you can probably need to do in a controlled setting like ICU.
Okay.
But in the ward, simple things like pulse pressure, urine output, and seeing whether the patient's cognitively are there. Now, if you're asking me how many ml, I would go by the surviving sepsis, 20 to 30 mils per kg in the first hour. Okay. Yeah. I think the more important thing is not how much fluids to give. For me, the important thing is how much fluid does the patient require to maintain my targets.
Okay.
Because you can give the patient as much fluid as you like. The problem, of course, is not in the beginning of sepsis; it's towards the end stage when the patient becomes edematous, and that becomes a problem. So I would say that if the patient is drowsy, you give fluids to try and target a MAP, an MEP. So giving fluids or any therapy for that matter to treatment targets is probably more ideal as compared to, say, just giving an arbitrary number.
So what MAP would you target?
So 65 is an ideal standard. Once again, I go back to the surviving sepsis guidelines. Those are generally universally accepted. So a MAP of 65, the patient is cognitively alert, not drowsy, because drowsiness is one of those signs of hypoperfusion.
Yep.
Urine output of 0.5 mils per kg per hour, right?
Yep.
These are just rough numbers. You can actually use to titrate.
Okay. And I think one of the things practically that people struggle is the very first bolus that goes in. So in patients, let's say with a bit of like CKD, a bit of, let's say, poor heart, people are a bit scared to give like a full, let's say, one bag at the outset. Should, in these instances, would you then cut back on the volume? Would you cut back on the rate that the first bag goes in to determine how the patient responds? Or in most instances, it's actually okay to give a full 500 mils and then see how the patient responds for the first bolus that goes in?
So, okay, this is a very nice question because there are two ways we can go about this once again. If this patient is alert and awake, I might judiciously bolus fluids because my targets have been met already and I'm merely treating a number. So you got to ask yourself whether you are treating the patient, which is if she's drowsy, I don't think that you should really worry about how much fluids you're giving because at this point in time, maintaining cerebral perfusion is actually more important. If the patient's urine output has dropped, I think you shouldn't also worry how much fluid you're giving because at the same time, you are targeting towards improving the urine output.
Yep.
Okay. As long as you've got treatment targets, give as much as you like. I don't think it matters whether you give the first bag or the second bag. There is another school of thought to acknowledge all of the people out there who say that less is more. And while I do agree that you can give less fluid, but keep in mind what's going to kill the patient. Is it fluid overload or is it hypovolemia? So when you're looking at shock, it's hypovolemia that kills the patient.
Yep.
I think you can always worry about fluid overload later on.
Okay.
So if it's a renal failure patient or a heart failure patient, if the patient is hypovolemic, I would give fluid.
Okay.
Right. How much fluid? As much as the patient needs. So blood pressure doesn't respond with 250 mils, I'll give another 250 mils followed by another 250 mils. If that's your concern. You don't have to waste the bag. You can run the first 250 mils. The question is over how long? Most people, when they define a fluid bolus, they give it over something ridiculous like an hour. You're not going to get much of a response because you need to target that atrial stretch.
Yep.
Right? So essentially what you need to give is over 15 minutes. Okay. So any fluid bolus you give over 15 minutes. There are other ways to assess whether the patient is volume responsive or not. And I think, okay, yeah, that will go on the next slide. I'm sure you've heard of the straight leg raising, right?
Yep.
Although almost none of us ever do it. I've only done it like possibly 3 to 4 times in my entire 2.5 years of ICU practice.
Okay. Do you think it's something that is feasible in the gen ward, or what's your take on it?
It is very feasible, but it has to be done properly. The expertise needs to be there. So the people need to be very clear about how to do it. Of course, the most important is how to interpret it. Yep. Right? I think it's a great fast test to do. You just lift the patient's legs and you don't instantly see a change in their blood pressure.
Okay.
But straight leg raising, so what if you're a bit fluid and I rarely do it. I end up just connecting the patient up to a bag of fluid and running it fast. Yeah.
Okay.
So
sorry guys, sorry I'm late.
Okay.
So as a general rule, I would say that if the patient is shocked or hypotensive, you can just go with a 500 ml bolus. Yeah. Over 15 to 20 minutes and see how the patient does.
Jared, just now you spoke a little bit about lactate as well, right? So, I mean, is lactate helpful in assessing, like, how much fluid we should give or as a number itself?
No. So the only thing is lactate as a number itself tells you if the patient is shocked, and lactate is a marker of like, there are some studies to show that high lactate numbers are associated with mortality. So if you look at surviving sepsis once again, in the guidelines, they mentioned that lactate of 40% is usually, lactate of 4 is usually associated with a 40% mortality, right? And a lactate of less than equal to 2 the mortality rate is very low. So I think it tells you the severity of shock to a certain extent and that the patient is shocked. But targeting lactate clearance, there are some people who tend to do it. I haven't done it and haven't found it very useful. But it is kind of reassuring that if you're giving a few boluses of fluid and your lactate has come down, that perhaps you are kind of veering the patient away from shock, right?
How frequently would you check the lactate in the gen ward setting?
As frequently as your ward would permit.
I mean, so how fast do you expect it to like respond to like a?
Well, I mean, to be honest, I don't have the knowledge about how long it takes. Rohan, do you have any ideas about how long does lactate take to clear?
So actually, that's a good question. I don't use lactate in isolation because I find that lactate is a very deceiving thing. It just, to me, shows a mismatch between supply and demand. And honestly, to me, the most important thing is that the patient responds to whatever I'm doing. And it may be something like the blood pressure going up, the perfusion improving, the patient becoming less confused. And the thing is that lactate-based therapy, right, will inevitably fail because it's just one marker. So I think you should check the lactate as frequently as possible, but more importantly, you should probably go back and check the patient. Because the tendency and temptation is actually just to click on the computer and check the lactate and not go back and check on the patient. And I think that's crucial. Yeah.
Are there any caveats with using lactate? Because there are other causes of raised lactate. So based on your experience, what are some of the things that may make lactate an inaccurate marker for sepsis?
Okay, so here's the thing, right? A high lactate is bad, but there are many reasons why the patient could have a high lactate. Some of them are actually quite benign, like for example, Ventolin-induced high lactate. Most of them are very bad. Like cardiogenic shock can cause a high lactate. Metabolic metformin-associated lactic acidosis is of course not good. And in summary, when someone has a lot of lactic acid, they are inevitably almost going to go into metabolic acidosis, and that in itself is no good as well. So, of course, we all know that there are type A and type B lactic acidosis. So the truth is that whenever the lactate is high, something bad is happening. When the lactate is low, usually look somewhere else for organ hypoperfusion or for a reason of hypotension. I mean, there are like hundreds of reasons, honestly. Yeah.
Okay. Just to backtrack a little bit on the question of assessing fluid responsiveness in the general ward. So sometimes what we observe is that a patient is a bit hypotensive, the resident gives a fluid bolus and the BP picks up. And then the resident is then happy because the BP has picked up because there's a response. But based on my understanding, when a patient is responsive, that doesn't mean that you should then stop at that point in time because it doesn't mean that the patient is necessarily adequately replete. And so I guess the question is, okay, let's say the BP in this patient that we talked about was 80 something, 50 something, and you give her bolus, it goes up to, let's say 95, 65, for example. What should be the next course of action in this patient?
So as a general rule, what I would do is, I think it's very important to ask ourselves, what is the cause of the hypotension?
Yep.
And causes can be varied. Some can be as simple as, oh, a patient has picked up a new infection. But I think the most sinister causes worry me a lot more. Things like silent infarctions, patient had an MI, they may not have any pain, and it's not something that's in the top of our mind. Massive pulmonary embolism, these are other causes. Addisonian crisis, hypotension as well. So these are the other things that we tend to think of less often, and we wouldn't as a first line go there. Most time we tend to think of everyone as having sepsis or septic shock. And it's actually, it couldn't be more far from the truth because there are lots of different things that cause hypotension and shock itself. And if those are not attended to, those are actually far more time sensitive than sepsis itself, because sepsis, as a reflex, most of us tend to over-prescribe antibiotics for most patients. There's a whole subset of patients, and I'm sure Rohan can attest to that, that would have benefited from early steroid administration, early thrombolysis, etc.
Yeah, so I mean, I'm a big fan of fluids because I think most patients in the ward are actually dry. But the thing is that we have to know that hypotension is just an endpoint of many different diseases. And patients often don't just have one pathology, they often have multiple. And the only thing that a bag of fluid cures, right, is number one, the blood pressure transiently, and number two, hypovolemia. Everything else, right, it doesn't cure. So I guess the reply to fluid bolus, BP go up is great, but have you actually fixed the underlying problem? So if this lady had been vomiting like 10 times a day for the last 5 days and you gave her 500 mils of fluid, you probably fix the hypovolemia part of the equation. But why is she vomiting? Does she have DKA? Does she have UTI? Does she have an atypical presentation of MI? All these things, a bag of fluid will not cure and will actually inevitably make the condition worse. So I think the main thing here, right, that we always see and where people always fall down is that it's nice to know that lactate is a marker of hypoperfusion, but actually the truth is that we are not curing lactate or we are not curing a blood pressure. The most important thing we have to realize is that we are trying to fix the patient. And the thing is that the things we do may help one thing and hurt another. That means if you give too much fluid, the patient will become soggy. And then subsequently, they'll become difficult to ventilate. Or for example, if you did not calculate the amount of sodium you're giving or water that you're giving, your patient may actually end up hyponatremic or hypernatremic. So I think everything has its upsides and downsides. And fluid is great, but it's just a temporizing measure. And I think it only cures in very few situations.
Yeah. Okay. So as I was mentioning earlier, I think fluid is much like the thinking fast aspect of it. You start to run the bag of fluid, it buys you time to think slow. And I think that's very important. You should never think fast and leave the patient. You should think fast, use the time to think slow, go through the different causes and think about whether these are the things that I need to worry about. Then you can be assured that whatever your response is, the blood pressure will then remain when you walk away, remain up or may go up or even improve when you walk away from the patient. Because the last thing you want to do is to walk away from a hypotensive patient.
In fact, I think the most important key, right, is to actually reevaluate the patient. Because when you reevaluate the patient, you will gain two very valuable pieces of information. The first thing is that you will then realize, okay, what is my patient like now? The second thing is that you will realize whether you're right or wrong. And often in medicine, the truth is that it takes a long time for us to know whether we are right or wrong, especially if we are talking about clinic work. But for resuscitating a critically ill patient, the feedback loop is very, very short. You may only have like a few minutes or even a few seconds to see if your patient is improving or not. And if you don't respond with that kind of speed, right, you are always going to be 2 steps behind. So I think the most important thing is that you just have to keep getting more and more information, and you have to realize whether the first set of assumptions that you made, because every time you see a patient, you are making some assumptions, was actually right or wrong. And that is the key.
Yeah. Okay. Thank you very much. Just two lead-on questions to two things that Dr. Jared mentioned earlier. So the first is the use of pulse pressure. Dr. Jared, if you can share with us how we can use it in the general ward, because it may not be something that residents are very familiar with. And the second is about the threshold of use of steroids in hypotension, because you can't do a 8 a.m. cortisol, you can't do a synectin test at that point. So when would you suspect either adrenal or relative adrenal insufficiency and start steroids? Yeah, so those are the two questions.
Jared or me? Sorry.
Either or.
Either, okay. So I just tell you my very simple rules of thumb, okay? Because we don't have a lot of brain space to remember things. There has to be some simple rules of thumb. If my patient is fluid refractory, that means I've given about a liter of fluid, I consider steroids. Okay, the truth is that many people are actually on low dose steroids and don't know it. Many people take traditional medicines and don't tell us. And the truth is that when people are very, very sick, this is when it turns up. And often you hear patients with mild abdominal pain, giddiness, and fluid refractory hypotension that actually turn around with just a jab of 200 milligram IV hydrochloride. You don't actually need to take a serum cortisol before you start it. What I usually do is I just add tests to whatever bloods I have done, just a random cortisol, and then I give my hydrocort. Because to be honest, there's very little downside of IV hydrocort as a stat dose in someone who is critically ill.
Okay.
The second thing about pulse pressure, I actually find it quite useful. Usually you'll see a very low diastolic pressure in people who are extremely hypovolemic or people who are in distributive shock. And if you see a narrow pulse pressure, you have to think of a few things. First of all is dengue. The second of all is cardiogenic shock. And the third thing is that your patient is very, very ill no matter what. And you should actually keep a close eye on this patient, because a low pulse pressure to me means that the heart is not pumping very good. And the patient is probably going to arrest if you don't do anything and don't find out what is happening. Yeah.
Okay. Do you have anything to add, Dr. Jared?
So I think pulse pressure, first of all, you probably need to know how to record it. It's actually very simple, systolic minus your diastolic, to give you a value. And what it essentially tells you is that what is the difference between your systolic and your diastolic pressure. You need to understand what your systolic and diastolic pressures are indirectly telling you also. So one is telling you about your cardiac output, and the other one is telling you indirectly about your vascular tone. Yeah. So these basically are telling you about your preload or fluid responsiveness. Now, it's very difficult to explain this without the Starling curve, but I think you can Google that and find out very easily. If you just Google pulse pressure variation with Starling curve, and they give you a very nice graph. You've got two graphs, one lined up here and one above it, right? To show you how you need to shift the patient in terms of stroke volume, how to improve the stroke volume for the patient.
So is a widening or narrowing pulse pressure suggestive of fluid responsiveness?
Sorry, I didn't hear that.
Right. So when we give fluids and we say that a patient is responsive, do we expect the pulse pressure to narrow or to widen?
Are you asking me or telling me?
I'm just asking it as a question to clarify.
Okay, that's a question. Okay. So, I mean, a widened pulse pressure is associated with the patient being very vasodilated. Okay. So I think you need to be very clear that as you give more fluids, if your pulse pressure actually narrows, that's actually considered an improvement in the patient's response.
Okay. Is there a threshold for beyond which, so if you don't see any more narrowing, then you would normally consider that as one of the markers to suggest the patient may not respond further? Is that
there
correct?
are believers and non-believers in that. I'll be to have a disclaimer out there. I remember NUH, I don't know whether they still have this protocol for assessing fluid responsiveness in the ward, the passive leg race and pulse pressure variation.
Yep.
Right. So pulse pressure variation actually is extrapolated, as you know, from stroke volume variation.
Yep.
And stroke volume variation, to be very precise, is measured only in paralyzed patients who are not spontaneously breathing on mechanical ventilation. So basically, you're controlling all of the variables and you're looking at stroke volume differences, and 12% is your cutoff. Now, in pulse pressure variation, well, they're trying to extrapolate all this information and try to move with that. I think it's 15%, if I'm not mistaken, as the cutoff change.
There are different thresholds depending on who you believe, because if you want a higher PPV or lower NPV, there are different cutoffs. But I think, Jared, you're right. There are just too many interfering factors. So even, for example, taking the blood pressure is in itself a confounder, possibly. So I think for me, pulse pressure variation is a little bit too difficult to use in an uncontrolled setting. Because when you give fluid or when you're reassessing a patient, actually there is a huge difference in terms of capacitance, stroke volume, vascular tone. All of these vary. The patient is probably better. Leg race is also good. Yeah, I use it a lot.
If the patient has a widened pulse pressure, then these probably give you a clue. So essentially, in summary, I mean, with regards to assessing fluid responsiveness, no one marker is going to give you a full picture. Much like just looking at one part of the jigsaw puzzle is not going to give you an idea of what the entire puzzle looks like. Okay. So what I would encourage all people who are assessing patients in the ward is to try and pick the pieces up of the jigsaw puzzle and lay them out in front of you. Only then can you get an idea of what exactly you're looking at. Okay. Things like hypotension with simple hypotension on your non-invasive blood pressure, concentrated urine in the bag, a patient who appears dehydrated, and maybe an IO chart that shows that she has not been eating and drinking well the last few days. It all tends to fit the picture in together.
Yep, got it.
So
And pulse pressure is just one of those things. Yeah, sorry.
thanks, Jared. So how about things like choice of fluids? Is there a particular fluid that you recommend for residents to pick first as choice of resuscitation?
Rohan, do you want to have a go at this one, or do you want me to go? I really love this topic because it's really fun. Everyone keeps asking this.
It's okay lah. I'll just use one word, and that's Hartmann's.
Okay.
Yeah,
I think what you want to say is
Hartmann's.
balance all solutions, or things that are as physiologically close to what we think is physiological to begin with. So you need to know how much the sodium is roughly in the intracellular, because the main key players in osmolar shifts are sodium, urea, glucose, right? And you don't want you don't want large amounts of salt in the extracellular fluid. Let's put it that way. And that's because there are some studies that show that patients who were resuscitated with hypertonic saline, well, not hypertonic, but rather more than physiologic, which is just what we call normal saline. Yeah, which is completely abnormal. Okay.
Abnormal. Yeah.
Because the sodium inside that is 154 and the chloride inside is 154. That's way more than the 145, what we think is physiological. Those patients were associated with a high incidence of requiring renal replacement therapy downstream. These are intensive care studies though. So my recommendation is, I agree, I think it sounds pretty reasonable. If you're living in a resource staff setting and all you have is a bag of saline, I guess then that's the best you can give the patient, right?
Yeah.
But you must be aware that you are loading chloride into the patient and increasing the risk of NAGMA, and that will lead to increased incidence of RRT requirements.
Okay.
So the very simple statement is, stick to the fluid that is most physiologically balanced. Now, as Rohan rightly pointed out, Hartmann's is what we tend to use in the wards. And I think that's pretty safe, but you must be very clear about what Hartmann's contains and how much we're looking at. So sodium residue about 130, but Hartmann's does contain a small amount of potassium. And I think that's very important to be aware of. So in hyperkalemic patients where your potassium is 7, and if you're giving the cocktail and you're resuscitating with Hartmann's, there's a possibility that the potassium may not go down. And actually you are going to prolong the period the patient is exposed to hyperkalemia.
Okay.
So I would be a bit careful in those patients.
Okay.
But if the patient is really volume depleted, then any fluid doesn't make a difference, right? Because it's just volume that they require. Now, some places where they have the possibility to use more cheap solutions, plasma light is a great option, yeah.
Okay.
I would discourage you from using colloids and hydroxyethyl starch. We almost never use starch in Singapore. Starch is very bad. It's just moved out of the guidelines completely.
What about albumin?
Colloids we discourage as a first line.
Albumin 5%. Yeah, albumin 5% is the usual colloid we use.
Okay.
Yeah, but I would discourage using it as a first line because most of the studies show that albumin used after a certain amount of fluid is given is probably better than just giving albumin alone.
Okay. Is there any role specifically for patients who have low albumin? Because some people I noticed may give albumin because the albumin is low.
That's kind of saying let's give the patient sodium because their sodium is low, or let's give them potassium because the potassium is low, or let's give them some lactate because the lactate is low.
Okay.
Yeah.
They kind of have.
Yeah, so we know that there are open label trials, right, where we actually replete albumin in people who are septic. There was actually no mortality benefit. So what we are actually doing is doing our best to manipulate the physiology, assuming that albumin, which is existing in the intravascular component or compartment, will actually draw fluid into the intravascular compartment. I view it as kind of like an additional tool in my arsenal. I sometimes hope and pray that it works. Honestly, I use it when people have low albumin, it's true, or when they are refractory to quite a lot of crystalloid administration. But I wouldn't bet on it, to be honest with you.
You also need to know how these fluids work because fluids have this...
They third space eventually. Albumin disappears from the body in 72 hours. So what you're doing is just giving them a longer lasting fluid bolus, which will disappear in 72 hours. But if you're willing to accept that, then that's fine. Because patients who are ill live their life not in days or weeks, but in hours, you see. So if you can buy that time, then that's great. So that's when I use albumin, 5%.
Yep. You can use albumin also in patients who you think where they are cirrhotic. I think in those, there's lots of evidence to show that if they're hypoglycemic, albumin is a much better fluid to resuscitate them with. But coming back to your question about whether we should look at albumin as a number, I think you should look at the fact that if the patient's albumin is low and the patient is hypotensive or shocked, these are actually very bad signs. It goes on to suggest there may have been a chronicity to whatever chronic disease is occurring in the background.
Okay.
And the patient is not the best substrate to begin with. So now when you have a new event like sepsis on board, the mortality is much higher.
Yeah. So
that's what I take when I see that albumin level. But as to giving albumin as a resuscitation fluid, there are plenty of trials. I mean, there's the SAFE trial, and then there's the Christmas, and there's a whole bunch of other trials you can go and read about. Yeah. I can share them with you at the end of this talk.
Okay.
But essentially, the take-home message is crystalloids first. Consider colloids when when you've given about 2 to 3 liters of crystalloids.
Okay.
So this is just a rough measure.
And I think I have to throw in a word of caution here. I used to be quite aggressive with my fluid resuscitation. I used to give at least 2 liters before I would consider switching to colloids. And I mean, I do still feel that ward patients tend to be on the dry side, but by the time they get referred to me, I tend not to ask the team to give any more fluid bolus and actually start to evaluate for early vasopressors. Okay. Because the thing is that when patients are profoundly ill, it's actually very, very difficult to get the fluid out of them. Yep. And we don't want them to get too soggy because most of the time this third space and it leads to a lot of problems. Yep. So I guess the take-home message about fluids is try to give enough but not too much. Try to use balanced salt solutions when you can. And I noticed that you had this part about specific and special circumstances. Actually, there are very many. And I think that is really something that we can talk about in another lecture. Sure. But in summary, you just have to look at your patient. Make sure you don't give abnormal saline too much. Try to think about the things you are manipulating. Are you manipulating the intravascular fluid, the extravascular fluid? Are you manipulating water and are you manipulating sodium? These are the few things I think about when I give fluids.
Okay. I think also at the other end of the spectrum, just to add on, there are certain group of patients who may have, like Rowan pointed out, more than one etiology, in which you shouldn't also conversely deny them fluids. So the volume contracted DKA is someone who benefits tremendously from large volumes of resuscitation and should not be denied that. Okay. The volume contracted diarrhea patients who've had massive amounts of fluid losses, you should not deny them fluids. The actively bleeding patient should not be denied volume expansion. So
blood,
that is the other thing I'm going to talk about.
Blood. Yeah, blood.
Well, yes, whether it's blood or fluids, whatever it is, yes. So my point is you shouldn't be denying them that, right?
Yes, yeah.
Just because you want to be conservative. I think if you're talking about specifically sepsis in the ward, yes, I agree with Rowan that fluids reevaluate after. So what, as a general rule, I do is I reevaluate the need for fluids or the type of fluid at the end of every pint. So if you use that as a general yardstick, I think you should be fairly safe because it makes you stop and think about every pint of fluid that you are giving. So I generally try to avoid ordering things like give 1 liter over 1 hour, right? Instead, I would say give 500 mils over 20 minutes. So it forces me to reevaluate after every 20 minutes. Because then the nurse will turn on to me and say, doctor, the fluid bolus is up and the systolic is still 90. Versus the nurse calls me 1 hour later and say, doctor, the patient's pulse or BP is unrecordable. So it also encourages you to sort of have a smaller threshold or rather lower your threshold with regards to reviewing the patient in a timely manner.
Okay. So
is there going to be a section about common failures or is it here? Is it all?
I guess we can either do it at the end or in terms of the fluid point of view, if there's anything you want to raise here at this point.
Yeah. So here's the thing, right? A lot of our patients have ESRF or low EFs, many of them. And often these patients have come in with abdominal pain, diarrhea or vomiting. And the thing is that people always just give 500 mils of fluid or 250 mils of fluid as a resus fluid. And then they call me saying that the patient is hypotensive. So after listening to the story, I always ask them, do you know what's the dry weight? And they haven't checked. And then I ask them, have you weighed the patient? And they haven't checked. I asked them to check. And then lo and behold, the patient is 2 kg below dry weight. So I want to emphasize to everyone, right, that just because someone has a low EF or has ESRF and is not clean, it doesn't mean that they don't get fluids ever. Actually, they can become hypovolemic as well. And I think the key here is to use everything. Look at their dry weight, look at their tongue, take a proper history, examine them carefully. So then don't just base on history or rather their past medical history and deny them medication or fluid just because you think they are at risk of overloading. Always assess the patient.
Okay, thank you very much. So I guess the next question is sort of a segue to what Rowan mentioned about perhaps at some point in time you need to start thinking about pressors. But of course, there are limitations to pressors given in the ward. Sometimes we may give a bit as we await like ICU bed, or maybe in some instances the patient is not really the best ICU candidate. But in those instances, I guess we should be reviewing whether we should be even giving it in the first place. But maybe a quick word of what can be given in the ward, and perhaps whether like as a bridge before ICU, is it something you would recommend?
Okay, so I think it's fine to give vasopressors in the ward, but you need to know what you are aiming for. I don't like to give anything without knowing what I'm going to do in the end. So I'll give you some examples of when I use dopamine in the ward. So sometimes the patient is not a candidate for any further invasive therapy, but his blood pressure starts to drop. He's extremely third-spaced, he's on NRM, and I truly don't want to give him any more fluids. His blood pressure is 50 systolic. But we know that there is a family member flying in from China and he will touch down tomorrow morning to see his grandfather. So I will choose dopamine then because I don't want to overload him. I accept that he may die from an arrhythmia from high-dose dopamine. And so that's the risk I take. So in those circumstances, I will tell you, go ahead and use dopamine. Yeah, because fluid will actually make the whole situation worse. And the option is to let him pass away without seeing his grandson for one last time. So there is one example I always tell people that please go ahead and use dopamine. There are some cases whereby I would recommend it with reservations. So for example, if ICU is very, very busy and this patient has just come back from a procedure and now he's hypotensive again, and you know that he has a normal heart function and ICU only has a bed free in 30 minutes and you have a big plug, he has no IHD, I would probably consider starting either peripheral dopamine at a low dose to maintain blood pressure or even phenylephrine, okay, under ICU supervision. Because I know that this patient is going to ICU and if there's any problem, I can consult them, okay. The third time where I would use vasopressors in the ward is of course post ROSC. Let's say the patient has come back but is in a tenuous state. You can for sure start IV adrenaline, IV adrenaline, IV phenol, or IV dopamine through peripheral plugs while you're waiting for patients to be transferred to ICU. So these are three scenarios I usually would advise you that you can use dopamine or phenylephrine in the ward. You can actually run adrenaline through a peripheral plug as long as it's big. There are studies that show you can actually run it for up to 12 to 16 hours without significant problems in the upper limb where you're running it through. But the studies usually put it in big plugs in the antecubital fossa. But if they couldn't get it through the antecubital fossa, they actually used the dorsum of the hand. And there were no reported complications. That said, I feel very uncomfortable if it's in the dorsum of the hand, and I usually only run vasopressors through the big vein in the antecubital fossa. Yeah, so in summary, you have to know what you're doing. Yeah. If you think that the patient can take it, then go ahead. But you have to have a plan. Yeah. If there's no plan, don't do it.
Okay, sure.
Can I actually share my screen?
Sure.
Okay. I'm just going to share it right now. I don't know if you can see.
Okay. Are you sharing now?
See?
Hang on. Can you try again?
Okay, wait. Exit, minimize window, share screen. It should actually be showing this.
Yes.
Okay, cool. This is a slide I made a very long time ago, but I think it still holds true more or less if you're looking at it now. And the reason I'm actually sharing it is because you're probably going to record this and play back, and I'm sure some of the juniors will want to read through. But it's very good to eyeball as to what is the osmolarity of the fluid you're giving, and looking at, we always talk about how to measure serum osmolarity, etc. But if you look at it, the osmolarity of so-called abnormal saline, as Rowan lovingly calls it, is 308. So it's quite higher than as compared to the rest. And Ringer's lactate or Hartmann's, which are fairly similar, both of the fluids, they somewhere sit around 275, which is closer to more physiological numbers. Okay. One other thing I wanted to mention earlier about fluids was volume expansion. I think that's very important. So if you look at it, right, the more colloids you have, the faster you will expand. So things like starch, albumin, dextrans, gelatins, they tend to volume expand much more than crystalloids. So if you want that stretch early and quick, then yes, colloids do help, but ideally you shouldn't stretch them too fast. That's my experience, because if you push them further along the saline curve, you then get what is called, you make them more soggy, as Rohan mentioned. With regards to albumin, I just wanted to quickly show you this so that you guys can go back and read about it. So they compared, in this SAFE trial, they compared albumin versus normal saline. And they said mortality may have been reduced when using albumin when they looked at the meta-analysis. But otherwise, in the SAFE trial itself, there was no difference in mortality. Okay. And if you look at this, which kind of, this forest plot, which kind of tells you about all of the different types of trials that are used, it kind of tends to favor albumin being the second treatment. Okay. So I think albumin is a good fluid to use, but at the end of the day, we probably want to make sure that you've given a decent amount of crystalloids. I'm going to use the word decent amount, right? Because I think, as Rohan rightly pointed out, don't flood the patient. If the patient is a 10 kg or 5 kg or 15 kg person, be judicious. You might not be able to go with 30 mils per kg fluid. You might have to be something smaller. Okay. As a general rule, 1 to 2 liters in the first 30 to 60 minutes is fairly reasonable, but don't give it all in one go. So maybe give it in small aliquots. Okay. The trial that we had based all of this early fluid resas is REVERSE trial, right?
Yeah.
And in that, the treatment arm got more than 2 liters as compared to control arm, which in this day and age, we would never give 2 liters to a patient at any point in time. Okay. To go back to the pressors question, my simple answer is, if you are familiar with the type of vasopressor you're using, then go ahead and give. I, as a general rule, do not like dopamine, and I rarely use dopamine. And the major reason why you don't use dopamine is because, number one, it is a very dirty drug. Number two is it takes some time to prepare. And number three is it has very bad side effects, most notably arrhythmias and severe nausea and vomiting. So as a general rule, if the patient is alert and they end up vomiting on you, that's just going to give you more complications and more things to deal with. You don't need a hypotensive, drowsy patient vomiting away. You don't need them to have arrhythmias. It may actually hasten death. So dopamine has actually generally fallen out of favor. It is usually, as Rohan rightly mentioned, used as a last line effort. Personally, if you want to stick with clean vasopressors, you need to be very clear on how to dilute them, how to administer them, and what to watch out for. There is no such thing that peripheral dopamine does not cause extravasation or less extravasation as adrenaline. This is some wrong myth that has propagated down the years and resulting in this preference for dopamine over adrenaline. I love adrenaline a lot. Noradrenaline, these are excellent drugs because they are targeted therapy and they're actually evidence-based. But you must be very clear that any vasopressor given to a peripheral line, if the peripheral line is not a good flow in the antecubital fossa, large bore, it's actually going to cause extravasation. And the problem with extravasation with vasopressors is actually it's actually quite bad. It can result in the skin completely denuding off, including damage to the lower tissues, and they may actually require reconstruction at a later date. So, so these all carry their own risks. I think be very clear. If you look at our current eTROLI and Ungting form, we have a few drugs in there. There is ephedrine in there, and that's actually a really nice drug to use. Of course, the caveat being it can cause profound tachycardia or rather worsen tachycardia. But short acting, easy to dilute, easy to dose. My simple answer to people is, if you've never given it, don't give it. Simple. But if you have given it once before under supervision, go ahead. If that's something that you need to buy time, that's fine. But push dose pressors, okay, although they are coming up in terms of popularity, they require expertise.
Mm.
So unless your nurse is capable of administering them, I think it's a bit difficult.
Okay.
Things like phenyl infusions, I would not run in the ward. There are too many, even I wouldn't run in the ICU to begin with.
So I tend to use it, right? Because for some reason, it always takes half an hour to get a bed when I cope with patients. So I really rather not stand there and give boluses of ephedrine or phenol.
I can take adrenaline infusions. They're actually easier to clean up.
So the problem with adrenaline infusions, I find, is that lactate tends to climb after it. And then every time you give adrenaline infusion, the nurses are very slow then to transit patients back to other vasopressors after you have put in the line. Then you will see the lactate start to climb to 6 or 7, and then everyone will be on the fence overnight thinking whether you need to scan the patient for ischemic bowel or whether the sepsis is getting worse or not. So I think you can see, right, that there is a significant variation in practice even between the two of us, considering that we are both AIM and ICU trained. We both have different views on the matter. But I think we overlap significantly in two things. The first thing is try not to give vasopressors in the ward unless the patient is dying and going to ICU and you have no choice, or they are dying and you want to keep them comfortable, yet there is some unfinished business left to do. Yeah. The second thing is that I always prefer, if you are trying to rescue the patient, save them and bring them to ICU, to use a bolus presser, which I didn't mention actually, my bad. And the reason why is because it will actually force you to go and re-evaluate the patient. You can never leave a hypotensive patient on vasopressors unless they are DNR. Yeah. So,
in which case, you should not be giving vasopressors to DNR patients.
You can. So, Jared,
Okay.
if my grandma is dying, right? Okay, fine. Yes, this is where
that does not need to be a drawn-out affair. So
yes, it doesn't. Okay, we are participants in this drawn-out affair, but to be frank, sometimes people have unfinished business, and we need to help them. Yeah. So in that case, I would give and strongly recommend you to give peripheral infusions, of which actually, even though nurses nowadays are not familiar with most vasopressors, the most familiar they are probably with is dopamine. Okay, so you can usually find some very old nurse who 10 years ago has given dopamine and can therefore instruct the nurse how to give dopamine. If you cannot find any nurse, ask the ICU nurses, they will be able to help you.
So the other thing I think one of the most important lessons I learned with regards to vasopressors, right? Speaking of the dopamine, the deadly dopamine, okay.
Not that bad. It's okay.
So, okay, one of the most important lessons I learned actually was not from how to use these vasopressors is not from an intensivist, but rather from a palliative physician. And I think the very good analogy they used was, what are you trying to achieve with the vasopressor? So they used an example. At that time, I was a junior resident, and the example was, think of a vasopressor as a bridge. And I think that's a lovely analogy. If the patient is going to heaven, try to bridge them to where? What is your final destination, right? So what are you trying to use the vasopressor for? Because they really are a bridge. They are much like how you use ECMO. You can't ECMO the patient forever, never, never. You need to have a final definitive therapy, heart transplant or LVADs, whatever. The same way vasopressors. Are you trying to send the patient to ICU where he or she is going to get proper therapy, blood pressure supportive therapy, like stronger vasopressors? Then by all means, go ahead and give the vasopressors. Are you trying to buy the next 5 minutes so that you can push the patient to the nearest unit so the patient can get, yes, correct. So the patient can get thrombolized. By all means, give vasopressors. But are you trying to give vasopressors just because you do not know what's going on, or because you've given too much fluid? I think those are bad reasons to think about vasopressors. So you should have a fairly clear goal about why you want to use the vasopressor, right?
Or anything
in general. To the patient, or given too much lorazepam to the patient, or given too much propofol to the patient, and the patient is hypotensive, by all means, go ahead and give a push-dose vasopressor. Yeah. So there must always be a good indication. Don't give it because the patient is hypotensive and you've not given anything else, because actually they can be very detrimental. If you give someone a vasopressor when they have not been fluid loaded, once again, go back to the Starling curve, you're going to increase the afterload to the point, they will arrest. Yeah. From the increase in the vasoconstriction. Okay, or worse, you can increase the tachycardia, which will reduce their stroke volume. So you have to be very clear. So every time I see a hypotensive or shock patient, before I start large amounts of fluid, albumin, or vasopressors, I try to imagine where I am on the Starling curve and where do I want to go from there. And if I want to go in different directions, I have different algorithms to guide me along the way.
Okay. So we've actually discussed quite a bit about circulatory optimization today. Although initially we were planned to also discuss breathing and airway component. Perhaps you could shift that to another session. But I was thinking it would be good at this point in time to perhaps wrap up and maybe just focus on some take-home points for the residents. And I think for both of you, particularly, what are some of the pitfalls that you see and things that you want to really drive home to junior doctors and residents on the floor?
Hey, Jared, you say first. Then
I say first.
Yeah, you say first.
Take-home messages. Okay.
There are many.
I think the most important one that is, which we hear every single time, and when it doesn't really occur to us, is call for help. 2 eyes are better. Well, 4 eyes are always better than 2. I should not say 2 eyes are better than 1, because we do have 2 eyes, unless we have 1 eye blind. But generally, it's always better to have a second pair of eyes to look at things. Number 1. Or rather even discuss the case with someone if you are concerned about the patient. Sometimes when I'm concerned about my patients, I always give Rowan pick up the phone, give Rowan a call and say,
yes, any time of the night.
Yeah, even if it's the middle of the night. And the reason I do that is because it actually bothers me enough to actually discuss this case. And it's better to have someone else think of things as well from a different perspective. Because remember, bias is something, anchoring bias, whatever bias you have, these will make you see things from a colored lens. And it's always good for someone else to give you, hey, Jared, but did you think of this? Or did you think of that? So discuss the case when in doubt. And make it a habit to discuss cases, because if you make it a habit in a very young stage, when you get older, it becomes much easier to try and synthesize your thoughts. Number 2 is try to make it a habit to review the patient often when the patients are sick. And what I mean by that is don't give therapies that kind of encourage you to review the patient 2 hours or 3 hours later, because the next time you'll be seeing them is in the mortuary. So my simple recommendation is things like 20 minutes to 30 minutes is a good kind of yardstick to kind of review to sort of schedule the next review of the patient. Okay, don't leave patients on hourly parameters and disappear for hours on end. That's actually not valuable at all, right? I think if you're going to give the nurses a reason to record the parameter every hour, you should be kind enough to come back and see the patient the next hour, because they've actually done the work of recording the parameter in that period for you. Okay, yeah. Number 3 is if you need help, call for help early. If you're unfamiliar with any drug, don't give it as a general rule. Okay, either you ask someone who is familiar, or you quickly familiarize yourself with it. Okay, or once again, call the registrar. A lot of times, I've noticed that the resident has tried different therapies but has never called the registrar. And actually, the problem would have been sorted out if the registrar was called earlier. So there is a reason why you have a medical registrar on call in every hospital. And I think that's one of the most important people you can rely on. They have a wealth of experience, and they might have been able to fix the problem a lot earlier if they were informed earlier. I think you should always think very closely about when you've given up to 500 mils of fluid or a liter of fluid, whether the patient is fluid responsive or not. That's actually very important. And if your patient is not fluid responsive and still hypotensive, then I'd be very, very worried, because now you have not solved the problem, and it has carried on for an hour, right? So time is myocardium, time is brain, time is everything, right? So whatever tissue is dying off in the process from the shock is actually currently dying as we speak. Yeah. So these are the probably three key take-home messages I have.
Okay. What about Dr. Tan?
Actually, I have to agree with what Jared said. So first of all, right, hypotension in itself is a very bad issue to put in your problem list. Okay, I'm a big fan of problem list, because if you don't have a proper problem list, you will never solve the problem. If I see hypotension on the problem list, it's a big red flag, because it means you have no idea what is happening. Okay, so hypotension is actually an end stage problem, and there can be multiple pathologies that lead to hypotension: distributive shock, hypovolemic shock, etc., etc. But you see, all of these descriptions are very vague, and hypovolemic shock, distributive shock, all of these can have multiple causes and multiple diseases as well. So I never like to say that I treat hypotension, because it's just like saying treat SOB or treat eye pain. It actually means that you don't really know what you're doing. And what you may inevitably do is just give what I call tampa measure. You actually don't treat the patient. You just treat the numbers by giving fluid or vasopressors and all of that. So I think what ICU has taught me is how to manipulate physiology. So I think you guys should definitely revise the Frank-Starling curve. You should definitely familiarize yourself with afterload, preload, and capacitance, and revise, right? For example, what adrenaline does for each, what dopamine does for each, what ephedrine does for each, what phenol does for each. Because all of these are very, very important. When patients have hypotension, you don't have time to go and think about why they are septic, this and that. You have to resuscitate the patient. And all of these are very, very important, because I think we didn't really emphasize this when I was a medical resident. But you also have to keep going back and looking at the patient, because often these diseases evolve. And then when you see the patient again and again, first of all, you figure out what is happening, not what has happened or what has happened before. You will then get some further information and figure out what is wrong, what is right. And second of all, right, you will actually have time to catch the patients before they turn ill. So you actually have to keep going back and see the patient and figure out what is happening. I agree with what Jared has said. You have to be familiar with the medication, because many a time, right, when I'm in ED or ICU, I always make sure that I observe my resident dilute the drugs. And I always tell them a few things, which is always dilute the drug yourself. Have you double diluted yet? And I always remember that these residents or these MOs may not be familiar, because I have had cases whereby residents will just dilute the adrenaline once, and I tell them, okay, we are going to give 0.1 milligram of adrenaline now, okay? And then unfortunately, they give the whole syringe, and then the heart rate goes to 180. And then we just look at the ST depressions.
I think 200.
And the MO is like, oh, did I do something wrong? I said, well, it's okay. I mean, it has really happened. And then we just wait for a while. And I just pray that the patient doesn't stroke out or have an MI. So please try to familiarize yourself, not just with the physiology of the medication, but also the dilution. And please remember to be careful. And if it is 2 a.m. in the morning or 3 a.m. in the morning, please be even more careful with that. Okay, so yeah, you have to be familiar
know
with
your limitations.
Yeah, and yeah, I think whatever Jared said.
Share my screen for a short while.
What are you going to share?
Because I have this old presentation, but I think it's wonderful because some parts of it. Okay, so this is. I think if you can see the name at the bottom, this is Gattinoni, Critical Care to 2013. And I think that's a very meaningful statement for me. Try to look at the body's response rather than the values itself. So targeting a specific value is not going to be very useful. Some people may just be okay with a systolic of 90. Some people are okay with a systolic of 85, right? Some people are not with a systolic of 120. It's hard to believe, but it's true, right? Some people may require higher blood pressure. So that's one important thing. To summarize is early recognition on treatment of septic shock. Like we discussed about fluid therapy, plenty of evidence to guide fluid therapy. Of course, call us if you need help. Okay. And my last slide, I actually like this one a lot. Okay. Be aware of your limitations. Okay. And be aware of how you were trained and what is your experience, because those essentially are the things that will guide how you respond to a sick patient. Every one of us is individualistic. And imagine if you had 3 people attending to a septic patient or even discussing it, it actually broadens the amount of things that you consider, because everyone brings something else to the table. Okay.
So when you discuss cases, right, if you actually think about the case before you discuss it, you are actually doing yourself a lot of benefit as well, because you have to summarize the case in your head. You have to figure out what you latched on as pertinent points. And then when you present the issue to someone else, you are forced to explain it in a way that is understandable to other people. Yep. So I think presenting cases and sharing your ideas is very, very important. And the second thing is that I suppose that this lecture or talk is targeted at junior residents. And the thing is that you guys don't have a lot in your data bank because you have just started working. The reason why we can talk like this is because we have seen hundreds and even thousands of hypotensive patients. So to us, things like looking at the patient actually makes sense, right? Like we can tell when the patient is septic, can tell when the patient is cold, diaphoretic, or just sick, right? So for you guys, the truth is that you just don't have that paradigm yet because you haven't seen enough to form a clinical gestalt. So you need to rely heavily on things like physiology, things like papers and studies. And while you do that, okay, you can't just base your knowledge on this. You need to create your own data bank. So my suggestion is whenever you look at this kind of hypotensive patient, conclude based on your physical findings and the objective things that you have, what you think the patient has. Then go and reevaluate and think, oh, okay, I'm going to give fluid because I think this patient is hypovolemic. Was I right or was I wrong? Okay, because when you do that, you are actually testing yourself. And when you test yourself and you know whether you're right or wrong, you can judge whether your judgment was correct. Okay, and that is true in most things in life. It's just that in the critically ill, it's very, very rewarding because you get the information loop right very, very quickly. And you can actually become very good very fast if you actually make the effort to observe and learn. And if the patient tolerates, right, despite that, then you can ask us what happened, right? Because hopefully we save them. Hopefully we know what's happening. Not all the time, but we will probably give you another idea of what's going on. So that's my advice to you. Just keep seeing patients and not just see patients, but think about what is happening and see whether you are right or wrong.
You know that there's like a whole theory and book on analytical decision making, and critical care has books on it as well. One of the best ways to approach most medical problems is recursive, just to go back to the problem when you haven't solved it. Yeah. To think about what you have is in the process, even if you have tried something and it didn't work, essentially what you have done is eliminated that thing. So what you're left with is essentially the list of things, and there's only a finite list of things that can cause hypotension and shock to begin.
Yeah. And you have to figure out why you were wrong. That's the most important thing. Yeah, because sometimes we are wrong for very, very important reasons. Like last week, we saw someone who had a missed MI, and that's why everyone has an MI. Yeah, we don't want to have erroneous thinking patterns sealed into our mind. Yeah, everyone, chest pain is not to rule out ACS. There are many other dangerous things out there. Yeah, so I think it's very, very important to figure out why we are right and why we are wrong. Sometimes we are right due to a fluke, and we shouldn't pat ourselves on the back for that. Yeah, but if we are wrong and we gain a valuable message from it, that's actually good enough for me.
Okay. Yep. Thank you very much. I think we had a very fruitful discussion, both looking at some of the practical tips, the physiology involved, as well as perhaps some of the bigger picture things like how we make decisions and how we think about our patients. So perhaps today we can conclude, and we could have another session looking at the breathing and airway aspects of managing the sick patient in the general ward.
Even more exciting. Yay.
Yeah, sure. Why not?
Okay. Thank you.
Okay.
Yeah,